All right, good afternoon, everyone. Welcome to today's session. I want to thank you for joining us today. My name is Cynthia Klein, and I have very proudly served as the project director for the Take Heart project. You know what? We've received a lot of interest in this topic and in this webinar, so I think you will really enjoy this session today. Some of our presenters may mention a little bit later that this team, this Take Heart team, is continuing to work on materials, so in the form of guidance, tools to help out with hybrid cardiac rehabilitation in the future. So we'll be working on that over the next few months, and we will be making sure to make it available to you as well, certainly by the end of the calendar year. In the meantime, let's go ahead and move into some of the housekeeping items, and then I will move us over to the presentation. So this is the final module of a 10-module series for the Take Heart training series. As we've mentioned in the past, all of our training materials have been guided by the Million Hearts AACVPR Cardiac Rehabilitation Change Package, which you can find on our website. After today's session, you will receive additional guidance through the implementation guides that we hope you have found really helpful for each of these modules. And then your final peer action groups will be held after this session as well. And that's that opportunity, that one last opportunity to, share some of your successes, your ideas, and get some support from the group. We may have a few questions in this next peer action group just to get some feedback from you as well in terms of, how this process has been for you, what's worked well, maybe some additional things we might be able to work on in the future. So really important to join those peer action groups in the coming week. As we've mentioned also in the past, there is the opportunity to receive CEU credits, and so we'll follow up in that email with additional instructions on how to do so after this session. And then kind of last but not least, one of the other things we like to focus on is some of the interaction between our participants. So as we've tried to do in the past, it's really important if you want to go ahead and use the chat function during this presentation. You'll be able to chat with your peers, you'll be able to chat with our presenters. Just make sure that you set the to field to everyone so we can all see your questions. Anything that we can't answer during the session, we'll either fold it into those additional materials that we're creating or look to find a way to get that answer to you in the future. And I think with that, I'm going to go ahead and pass it over to Steve Hines to take us through the rest of the session today.
All right, Cynthia, thank you very much. And we just wanted to share with you what's going on out in the field. And the first time we went through this, there were more programs participating. And so we asked them how extensively programs are using CR. And you get a range here. About half said that they just haven't done anything related to hybrid CR. But on the other hand, about 30% of them were actively exploring whether to create a permanent hybrid CR option. So that was an exciting result for us, and one that we're going to be elaborating on today in terms of why you might be considering that. We also asked, as you can see on this next slide, how extensively programs are using hybrid cardiac rehab. And what you see here is that when the programs are actively exploring it, a lot of them say that the issue is resources and reimbursement. And so we're going to be addressing those issues today. It's still a very fluid landscape, and so we can't give you any permanent future answers, but we can tell you what's going on at present. So a lot of programs are using it, and we want to really accomplish these learning objectives as we talk today. Understanding what hybrid cardiac rehab is and how it compares to on-site cardiac rehab. There are a whole range of non-traditional programs that might call themselves versions of cardiac rehab, and it's going to be important to distinguish between what some of those flavors are and what a true hybrid program is. Understanding why hybrid cardiac rehab is a valuable option, and then finally exploring options or factors you should be thinking about when you're assessing whether to add a hybrid cardiac rehab option. We can't tell you in a single session how to fully implement a hybrid program, but what we can say is that there's a work group that Stephen Katayan and I and Teresa Rada are leading, that is really exploring those issues and producing a more extensive implementation guide that will build on the information that we're going to share with you today. And we're really excited about that. We're learning a lot as we go through that, and looking forward to sharing that with you. Now, so as we get into today's discussion, we'll talk about what hybrid cardiac rehab is, why you should understand it, and then how you can evaluate whether or not it might be something that you should explore further. Hybrid is not for everyone. And it's not for every program, but we want to give you a more informed sense of when it may work best for you. Now, the two panelists that you'll be listening today, Stephen Gatayan is a national expert related to hybrid cardiac rehab and other aspects of cardiac rehabilitation. And he's also going to be our respondent today, answering the questions that you put in the chat. And then Ann Gavitt-Ott is the manager of cardiopulmonary rehab and diabetes services at Northwest Community Hospital in Elk Grove Village, Illinois, and both are really insightful speakers. And will share how she got her hybrid program started from scratch in the middle of the pandemic. And Stephen will add his insights as well. So, Stephen, before we dive into the recorded comment, if there's like one thing that you want to cue the audience today to really be paying attention to as we go through this material, like if there's one thing that is really important for them to focus on as they process this, what would that one thing be? I'm kind of putting you on the spot here, but you're used to it.
Yeah, thanks, Steve, and welcome everyone. We started our hybrid cardiac rehabilitation program in 2016, and specifically to Steve's question, I would say the driving premise that we've moved forward on is to keep it simple and to keep it as similar to facility-based cardiac rehabilitation as you can. Paperwork, workflow, staff duties, keep them as like facility-based as you can so the staff can adopt them. Remember that we all tell our patients now to exercise at home on the days that they don't come to cardiac rehabilitation. All we're doing with a non-traditional program such as hybrid cardiac rehab is giving some shape and some direction and some data collection around what they're doing at home. So I encourage you to ask questions in the chat, and Steve Hines, I think I'm all set to move forward.
All right, excellent. Thanks very much. So at this point, we'll move into our discussion, recorded content of Stephen discussing some of the key terms that we want you to understand to help process the information.
I will say we have a lot of information to cover. I would encourage you to use the manual that accompanies this, as well as future projects that may come down the pathway for us to, grow on this journey as we move towards, an alternate delivery or another delivery model for cardiac rehabilitation. And it's important, I'm going to spend a couple slides on terms and definitions, and it's important we cover this because it really will set the foundation for not only what we cover today, but as you read the literature going forward and you talk to other people going forward, that we try to get on the same page. Facility-based cardiac rehabilitation is what we think of day in and day out, early outpatient, standard traditional cardiac rehabilitation. A new term for some of you, when we deliver facility-based cardiac rehabilitation, it's always face-to-face, right? It's synchronized with the patient at the same time. Well, there is another form of synchronized cardiac rehabilitation, and that would be for me to talk to you using a real-time audiovisual connection, your cell phone, WebEx, however you want to do it, and me observing you, let's say, exercising at home, or observe our patients while exercising at home. And then a third term that we have to start to think about would be asynchronous cardiac rehabilitation activities. And this means the patient is doing the activity potentially independent of cardiac rehabilitation staff. They're reviewing materials that were provided to them by email. They're reading online, educational materials. They're exercising on their own. They're loading their information, through a platform, or they may be talking to you about disease management, on a Friday afternoon, and they exercised on Thursday. So those are three key terms that we want to keep in mind. Next slide. Thank you. But what we're building towards is this fourth term of hybrid cardiac rehabilitation. And I'd like you to think of it just as the name implies, that there's some facility-based visits, could be 1, could be 10, could be 12, and those are intermixed based upon clinical need with both synchronized sessions, observing the patient while they're exercising at home with an audiovisual connection, and asynchronized connections as well, where again, the patient may be loading something up to a platform, totally independent, exercising on their own, totally independent of, let's say, potentially a cardiac rehabilitation staff. Right now, we're avoiding the words remote, virtual, home-based, because we're feeling that this may be adding to the confusion a little bit, because these words really haven't been anchored across the profession. So we're going to try and stick with today, and hopefully we get there, facility-based, synchronous, asynchronous, and a combination of those, hybrid. And these definitions come out of the think tank that Million Hearts conducted in the fall of last year. Next slide. So what is hybrid cardiac rehabilitation in terms of what is it and what is it not? So it isn't just exercise only. We tell all of our patients to go home and exercise without any direct supervision. We want you to exercise in your home, on your own at home. But without all of that means what is it? It contains all of the elements of cardiac rehabilitation. It's not just exercise only. It's not just education only, but it's the assessments, it's the counseling, it's the risk factor management, it's the behavioral support, it's the activity counseling, and it could be facility-based visits, it could be synchronized visits, it could be asynchronized visits. But it really is this multi-dimensional effort that we're delivering to the patient. Next slide. So still hammering our way on this same concept, but we're doing it now with a little bit more graphic. To the far left, you can see facility-based cardiac rehabilitation. Just as I said before, the black-bodied person, the blue-bodied person, they're in the same area, and one is supervising the other. Hybrid is a combination now of facility-based, again, the two people in the same area, and synchronized real-time audiovisual connection, where again, I'm seeing Anne, let's say, exercising at home, and at alternative times, could be synchronized, could be not, when the patient is or isn't exercising. We might be connecting with the patient in terms of educational materials, getting material from their devices, them reviewing materials, etc. So it's really a hybrid of the two. Next slide. So this is the Henry Ford model, and it's not the only model that's out there. We're wide open to other models, and it's pretty self-explanatory. We encourage the patients in our hybrid program to, just like everybody else, get to 36 total sessions. We want to shoot for that goal, and it could be through 2 to 3 sessions per week. We try to get in at least 1, but up to maybe 12 facility-based visits. That would mean 24 to 35 of their visits are synchronized audio-visual connections. And we may have asynchronous visits where we follow up with them at other time period about other information. If they're in facility, then we're doing ECG for some of those visits, not all, maybe just the first 3 or 6. Blood glucose monitoring if they need it, blood pressure monitoring if they need it. If they're home, we give them a pulse ox device that's for their fingers, so we can get their heart rates while they're exercising at home. We have internet available patient education. We give you a resource, a link for that. I think many of you may have seen it before. Home-based cardiac rehab would get you to the webpage, and then it's just audio PDFs after that. And like everybody in facility-based programs, baseline 30, 60, 90-day ITPs are completed, discharge reporting goes out just standard like we would do for a full facility-based program. Next slide. So let's pause for a sec, and I did all the talking, so I get to be quiet and develop the scope of how you got, how you got to where you're at today with your program.
Thank you, Stephen, and thank you all for attending today. I appreciate the opportunity to share our experience, and as Stephen said, ours is not the only, but it's been a really interesting journey. So to start with what created the need, it's been a little bit of an evolution, because I would say pre-COVID, the need was really created from the fact that we had long wait lists and our capacity seemed limited. And so in looking for an opportunity to expand that capacity, we really started looking at what we at the time called virtual or hybrid cardiac rehab, which, those definitions have now changed. And what we did was to offer patients a 1 day a week program, but the other sessions were done asynchronously. So we did work with a mobile app, so we had patients set up with that. So the other days of the week, they were reporting their exercise data to us. There was a library of education included in that, so we could assign them education and so on. With the onset of COVID, like most, I'm sure, we were closed for 4 months. And so that need really shifted to how can we provide cardiac rehab to patients who initially couldn't come into our center at all. And then when we reopened, many were reluctant to come back to a facility-based program. So that need really shifted to how can we provide cardiac rehab in some way and be effective without using our facility-based program. And then now that we're back to pretty much full volume, we recognize that there's a need outside of patients being reluctant to come back based on, travel, other access issues such as work and that kind of thing. So our implementation process, we moved to implementing a full hybrid program. Just to run quickly through that, our patients are encouraged to come live for their initial consultation. So we do their physical assessments, their functional capacity assessment, review of their paper assessments. We do all of that live if at all possible. We also take that opportunity to set them up on their mobile app so they have that ready to go at home for any asynchronous reporting. And after that, they start their synchronized sessions from home. We worked with our IT department they encouraged us to use an existing platform through our EMR. So there was a Zoom opportunity through that. So we used that for our platform. And then patients could link into the program, into their sessions through their patient portal. So they attend generally 2 days a week. Their synchronized sessions with us are 2 days a week. They link into the session. We do exercise during that session, and then after exercise, almost every time we do provide some live education as well. Every 30 days, we ask the patient to come back for a live monitored facility-based session to update their treatment plan and just to check in with them if at all possible. We also offer dietary consultation and smoking cessation consultation as separate Zoom sessions. So those are also done scheduled for the patient. So I guess lessons learned, it's quick, but lessons learned, what we found was that for group sessions, it's hard to do the exercise live and accommodate everyone's needs. We have some people that are very low level and some that are high level. So if they have exercise equipment at home, that works well. But if we're providing the exercise or we're playing a video, sometimes that's been challenging. It's also been more difficult than we thought to get patients to come back to a facility-based session. We try to schedule those up front so they have that on their calendar, but sometimes they get pretty comfortable with not coming into the facility. And then I think privacy issues are something else that we have to be really cognizant of discussing with the patient ahead of time, because there is some personal information that's exchanged via live audio visual, and so we want them to be aware of that. I think that's the time that I have, Stephen. So I'll toss it back to you.
Thanks very, very much, Ann, and that was a great summary. A couple editorial comments that just as I was listening to Ann, I wanted to comment on before digging back into the presentation. The first one is we've been asking our patients to exercise at home for decades. And so what we're doing now is we're just trying to give some shape to what we're already asking them to do. And for a lot of us, this creates problems or black boxes where we don't know where to go. And Ann said something that reminded me. It sounds like she picked up the phone and called her EMR people, her IT people, and they got involved to help solve how do we connect with the patients. And they were using it through their Zoom platform. Your IT departments, your care delivery, your virtual care delivery departments, especially because of the pandemic, are used to handling this now, and we can leverage that. We can leverage that to our advantage. We do about 1,500 to 2,000 of these virtual visits a year, and we got here because we just solved problems along the way, and you will too, in 2 or 3 years, get to about the same point. So that was my editorial comments. Back to the talk, and a little bit just about why cardiac rehabilitation and the benefits. So I want to move forward now as we start to talk about this information as we go on. First off, you can think of all the challenges and the barriers that patients have with respect to coming into a session, and with COVID, as Ann mentioned, coming into a facility with other exercising people was a concern. But these are also listed here are ones that you would think of that we would easily put 2 and 2 together and come up with. And the automatic referral and improved care coordination and handoffs from inpatient to outpatient will solve some of these, but not all of these. Next slide. So on the left, using diagrams again, on the left is a slide you've probably seen before at annual meetings. And the green heavy line, first outer circle, is patients that are never referred to cardiac rehabilitation. And the orange circle in the middle are the patients that are referred and start cardiac rehabilitation in a facility-based program. The red line are those patients right now in the US are few. They might be getting hybrid cardiac rehabilitation. And the blue line is they're referred, the blue circle is they're referred but never start. We want to get to the right. We want to make the circle in the middle bigger. We want more patients in a facility-based program. We want to shrink the green. We want more people enrolled, and that means the number, referred, that means the blue line gets bigger. The blue circle gets bigger, the number of people that are referred to cardiac rehabilitation. But in doing so, next slide, please. Go all the way over to the right. In doing so, we want to shrink that blue circle by also growing, not just facility-based through better referrals and care coordination, et cetera, but also grow an alternate approach to attracting these people. And that could be, very easily be, hybrid cardiac rehabilitation. Next slide. So one of the questions we often got when we started to talk about our program with others is, well, how safe is it? And we're going to cover a couple safety issues here. And these are some just twists you might want to think about as you start your program or talk to others as they start their program. We try to get, don't always get, try to get a stress test on all of our patients before they begin, screening for ECG issues, blood pressure issues. But if we don't get that, we'll see the patients in some facility-based sessions, at least hopefully 1, but maybe 3, 4, 5, or 6 before we let them go to synchronized audio-visual. So we're collecting a lot of that data through the normal monitoring that we would be doing in a facility-based program, rhythm, blood pressure issues, heart rate response, symptom management, et cetera. So we'll have that direct visual on them. And also we're going to still talk to patients while they're exercising at home. We'll get their heart rate response, we'll get their perceived exertion, and in some cases, patients will have blood pressure monitors and give us body weights, and we can do that both on and off site. So there's this, same type of surveillance or data managing or data following that we've had, whether it's in person or virtual or synchronized. And then we also do talk about the emergency plan with the patient. If there's a problem, what would be the plan that we'll follow? We do know we always ask the patient, what's your exercising site? And it's usually home, then we're okay. But if they're exercising at a hotel fitness center or exercising at work, we need to know that. And in some cases, we incorporate support people. So if it's a person that maybe needs a little bit more assistance for fall risk or communication, we may have a support person in the house as well. Next slide. So a couple other items about safety. I just want to emphasize there are no large randomized trials that have compared safety of hybrid cardiac rehabilitation to facility-based. They do not exist. Having said that, we do know, just by the nature of cardiac rehabilitation, that overall, the risk of having a problem in cardiac rehabilitation is very small for hospitalization, for a major event, or death. And that is a well-defined, well-understood, an event per, let's say, 500,000 patient hours, or 100,000 to 500,000 patient hours. The data varies. But I will also share with you that among the patients with stable heart failure, which these would be patients with class, C heart failure, NYHA class, 2 or 3 symptoms, the HF Action trial showed that after 3 months of cardiac rehabilitation, up to 1 year of home-based exercise in these people after finishing cardiac rehabilitation was not associated, and there was no supervision, was not associated with any increased risks compared to the control group. So I'm fairly comfortable saying that given good patient selection, given the status of the literature, we should feel fairly comfortable with exercising patients under good supervision, with supervision at home. Next slide.
Actually, Stephen, let's jump in and just check with Ann on her experience with patient safety at Northwest Community.
Good catch. Go ahead.
Yeah, thank you. We have more limited experience than Stephen as far as our volumes of patients, but I can say that we've had no issues with safety either. We do risk stratify our patients prior to having them join the hybrid program. We do not get stress testing on everyone. However, we do risk stratify and do recommend facility-based cardiac rehab for those who are higher risk. I do agree with you though, Stephen, you have a lot of experience obviously with heart failure patients, but we have had some stable heart failure patients in our hybrid program as well, and they've done really well. Just sort of, practical things, we are sure to get the patient location, phone number, emergency contact that the staff member has immediately available during the session. So if there is an issue, they know to call EMS to the right address. And then our physician supervision, we have our physician email and phone number, and we have the link to our session that we can send to the physician in the event that we need them to link into our session for any reason. So that's how we handle that physician supervision piece. And then I would just say, other than that, just really what Stephen already reviewed as far as, regular check-ins with the patient. We talk with them throughout the session, ensuring that they are reporting any symptoms or any change in status. And then certainly reviewing with them RPE and heart rates and shortness of breath and that kind of thing. So far, we've had no issues with safety whatsoever.
Hey, thanks, Ann. I did want to comment and say there are 4 patient groups that we do not automatically don't start into our hybrid program. Those are patients with a left ventricular assist device. Those are patients who are on milrinone therapy or an inotrope. Those are patients that are on dialysis. We do not enroll them in the hybrid program. And patients that are symptomatic at 2 mets or less. So there are some patients that automatically we do take out of the consideration pool. In terms about effectiveness and moving forward with kind of outcomes or the modeling of hybrid, the modalities that we would use for exercise at home are quite similar to the modalities that you would use in your regular facility-based program. It could be walking, If the patient happens to be a hospital employee and they're walking in the the basement hallways here at the hospital, and they might just be talking to us while they're on their cell phone because they've got good internet connection, through the hospital Wi-Fi. But it could be at home, it could be at fitness centers, it could be at community centers, and the same modalities that you see listed here. Next slide. We did generate a paper maybe a year or two ago. There is a stated concern that maybe patients exercise at home at a lower intensity than they do when they're supervised in rehab. And we generated a study out of one of our projects where we show that the intensity of training among people, and this is expressed as percent heart rate reserve, but the intensity of exercise training while patients are exercising at home was no different than the patients same patients are exercise training in a facility-based model. So the rigorousness or the intensity level was the same for both. And there have been several studies that have looked at the outcomes that we traditionally measure in cardiac rehabilitation, whether it's a hybrid model or a facility-based model, and things like quality of life, some risk factor management issues, and exercise capacity all seem to be similarly improved, not necessarily better, but certainly not worse than we would view in a facility-based program. And any comments from you relative to these same kind of effectiveness issues?
Yeah, I would say that our numbers are still small. So as far as comparative data, I don't think it's very reliable yet. So more anecdotally, I think it's just being cognizant of encouraging patients to do their exercise at their own level. We are operating in groups, small groups, and so it's important to encourage patients to do, to exercise at their level, whatever is appropriate for them. And if they have home exercise equipment, that's helpful because they can really titrate their exercise better that way. When we lead the exercises, we've vetted a bunch of videos, free videos, and we found some that have, higher levels, standing and, doing the exercises standing versus sitting, and we've used those and encourage patients to go at whatever level is most comfortable. So we've tried to address that in various ways. And then I would say outside exercise, the effectiveness of the program as far as encouraging risk factor modification, the education can be provided and the counseling for nutrition and smoking cessation and stress management. I mean, those are really easy to provide in a synchronous hybrid model. So yeah, I think the exercise probably for us has been the most challenging, but patients did, like I said, more anecdotally, but they certainly have improved.
Yeah, and thanks, Anna. I would just add that we've checked patient satisfaction, and the scores are off the chart. They really like the flexibility here, so that's just an observation. Next slide. So we're building demand, right? And there's our hope is to build even further. And there's a couple driving forces. We have an aging population, so not hopefully, but there will be more patients with qualifying events. And we're promoting this drive for demand, and hopefully we're getting there through better automatic referrals, and we're getting there through improved patient coordination and care coordination. And then the pandemic swings in, and there's just a whole host of other demand issues on cardiac rehabilitation. It could be short staff. It could be I want to stay away from the hospital because of infection. And we have to spread patients out, so we lose the ability to have as many patients in the room. So these are all, and so to speak, driving demand to driving a need to be able to cope with cardiac rehabilitation in a different way. Next slide. So that's what I'm trying to show you here, is that demand it can easily outstrip supply, and you've probably heard this commentary before. But if we fully loaded and tried to get into cardiac rehabilitation, all the patients that are eligible, or 70% of the patients that are eligible, we're trying to get them in, we'd far outstrip the capacity to handle it. Because if we ramped all programs to their full capability of existing programs, we'd only be able to handle 50% of demand. So we do need to look at these alternate delivery methods. In terms of some other things that hybrid cardiac rehabilitation might be able to help close or address, and it's some of these gaps in CR participation that we're aware of. And these are odds ratios or likelihood of participating in cardiac rehabilitation. You see those graphs going across the bottom of the screen. Non-whites are about 25% less likely to participate than white. Women are about 40% less likely to participate than men. Uninsured versus insured, a huge difference, and then educational level also. So there are some drivers here that potentially hybrid cardiac rehabilitation can help solve. Next slide. And there's not a lot of data around this, but it is worth mentioning, and that is the cost issues. And administrators, hospital finance people, they link into this. I understand that. And like cardiac rehabilitation, brick and mortar, facility based, we know it helps with hospitalizations, rehospitalizations, et cetera. So if we're broadening the people, broadening the critical mass of people that are exposed to cardiac rehabilitation by incorporating hybrid or getting more visits because of hybrid, then we're going to help in that way reduce hospital admissions as well. And in part of accountable care organizations, value-based plans, then this will be one way to help keep costs down. And because the operating costs for running cardiac rehabilitation are potentially lower in a hybrid model than in a full facility-based model. And there's some data to support that. So an important concern, a rightly correct important concern for all of you that are probably asking the question is, how do we finance this? What's the reimbursement model for this? Well, we know all the on-site cardiac rehabilitation sessions that would be hybrid in the hybrid model would be reimbursed by traditional insurance companies. So we're not taking those away. If they come to your facility, then you would bill them as usual. The patients that are then doing synchronized, audio-visual connection remotely, currently during the public health emergency, as long as it is maintained, then Medicare will reimburse it and coverage it under that covered under that paradigm. Now, whether that maintains going forward will depend on a lot of factors: future research, interest from those, drive from those that are currently doing it. But right now, it is a covered approach. I will tell you personally, Blue Cross Blue Shield in Michigan does cover it. I literally went to Blue Cross Blue Shield, made the presentation of what I wanted to cover, and before I even finished the presentation, they said, "Stop, we are going to do this." And working with your finance people to get an audience with Blue Cross in your state might be a reasonable thing for you to do. Medicare Advantage plans, private insurance, we have to continue to meet with these people, develop the data, demonstrate it. I know a couple hospitals that will say, we're not worried about the finances right now. You're a break-even program. Let's do this because it's the right thing to do. So others are working on this. We're working on this. We're advocating for this, but this will fall in line as we move forward. Next slide.
Yeah, and Stephen, before we move on, let me just acknowledge Karen Louie's input on those finance slides. We really appreciate her guidance on everything related to reimbursement issues for Medicare. So thanks very much, Karen. And then I also wanted to just check in and give Ann a chance to comment on how they've handled the reimbursement issues in their program.
Yeah, thank you, Stephen. I feel like in some ways we got started at just the right time when we were doing our what we were calling hybrid with asynchronous. Our thought was these are patients that we might lose otherwise. We were getting at least reimbursed for the facility-based sessions that the patients were coming to at that time, usually once a week. And they were doing, they were getting guidance for doing their home program and reporting to us through their mobile app. So that was our thinking at that time. And then when we moved to a full hybrid program, it was during COVID. So we have been getting reimbursed from Medicare patients. And also we're finding that most of the commercial payers are also following that right now. I am concerned for when or if Medicare decides that they will no longer cover this, potentially when the public health emergency ends. And I think what Stephen did in getting an audience with Blue Cross Blue Shield is exactly what we all need to be doing. I've only started my discussions with our finance department to say, what do we need to do in order to request that, we continue to be covered. I feel like I don't have enough data myself to present, but I can use that from the rest of you who have experience. So I really think that's the direction we need to go. I'm not sure our hospital will be as supportive in saying, let's continue this if it's a money losing proposition. But I think we can, we can figure out a model that will work to at least be break even.
So there's a couple of key questions as we go down this journey that we want to ask ourselves about hybrid cardiac rehabilitation. I'm not going to cover the column to the right too much. You can read that and wrestle with that information at your leisure in your companion manuals. But let's just talk higher level. And the first off is, does your program have low enrollment rates? And I think everybody would say probably so. We would like more MI patients, we'd like more revasc patients, but for sure heart failure patients. There's all areas that we'd like to improve upon. So the answer there would be a soft yes or a firm yes. Then ask your question, are you in or near CR desert? Do you reside in a place where eligible patients, it's just not feasible to access cardiac rehabilitation? A place might be the Upper Peninsula of Michigan, where the closest hospital might be, an hour away, and it's unreasonable for patients to make that drive. So we're kind of setting the tone now for a place that hybrid might help us fill. Next slide. So do you have, capacity issues? In terms of delay, Ann mentioned delays to get people in, or just the volume of patients that are coming in the front door, would be easier to handle them in another model. Hybrid might give you an opportunity to see an increased number of people in an alternate method without detracting too much from your staffing that would be in a traditional setting. And then do you have strong financial incentives to avoid hospitalizations, readmissions? I think that the answer to that question would be yes for most of us. We'd like to think we plug into that part of the care continuum that many of us are on in the care of patients with cardiovascular disease. Next slide. So will payers reimburse? We talked about this for synchronized real-time sessions. It's fluid right now. People like Ann, myself, Karen Louie, we're looking at this. AACVPR is tuned into this. This is important. We don't want it to go away, but this will help. This interest moving forward will help drive things. And the question is, can you do it well, safe, high quality? We don't want to do this in a parcel fashion. We want to deliver all the components of cardiac rehabilitation. It provides social support, and these are the things we want to include as we go forward. And any quick comment there about any of those? Then we'll get on to some of this assessment.
No, I just I particularly resonate with the last one. I guess I think doing it well is really important, and you highlighted at the beginning that what this isn't. And I think for anyone who's thinking about doing this, just ensuring that all the core components of cardiac rehab are included is really key.
So if you happen to use yes to most of those questions, then maybe exploring this opportunity of hybrid is something you should put on your radar screen. Slide. Next slide. So how do we induce this model for hybrid cardiac rehabilitation? And I would say thoughtfully, cautiously, let the data help guide you. There's many of us now that are willing to help others as you go down this journey. In the state of Michigan, we're talking about this actively, trying to help others in the state. come up to hybrid cardiac rehabilitation. The pathways can exist and others are willing to help. Next slide. So the literature is out there. There's some references that we've mentioned. Those will be at the end of the presentation. We encourage you to look at that. There's a home-based cardiac rehabilitation. Randy Thomas is the first author, put out by ACC and AHA, a good resource to look at there. And then, you know, you start to lay out the relevant groundwork. Who are your key stakeholders? Who are the decision makers? Who's your physician champion? Who's the administrator champion? Let them help appreciate, if possible, the importance of what you're trying to do. Get them to buy into it so they can start to speak on your behalf. And again, the timing is so appropriate because so much has swung to an audiovisual connection in healthcare. So they're thinking along that lines as they see care delivery. So lay the groundwork, start the conversations. Don't be bashful. This is what we need to do to speak on our behalf to do that. And then start to look at your own assessments. I mean, if you were to sit down and say, how do we put our arms around this? How do we give this shape? Who do we have to talk to? And you know, again, this might be IT or virtual care, your own staff. You know, can we do it at 2 o'clock in the afternoon? Can we do it at 5 o'clock in the afternoon? Can we do it at 7 o'clock in the morning? Can we do 1 class, 2? Start to give it shape and be more rigorous in your approach. And then assess your implementation options. And again, I alluded to that a little bit, but time of day, staffing matrices, days of the week. Maybe you're a Monday, Wednesday, Friday program, and Tuesday, Thursday would be good for you to go ahead and deliver this hybrid model. I do know for our staffing matrix, all of our exercise physiologists, not all of them, 6 of them, have a 2-hour block, 1 time a week where they cover the hybrid sessions. So they might have, let's say, you know, an hour and 15 minutes where they're connecting with patients by WebEx, and they've got part of that time to do their charting, part of that time to drop the bill, but there's allocated time for them to do it between about an hour or 2 each week. And somebody might cover the 2 o'clock class on Monday, somebody covers the Thursday at 4 o'clock class, and we've spread it out equally so it's not too burdensome on any one person. And just in terms of a little bit of tidbit, I wanted to let you know that when the exercise session is going on, a hybrid, we do it in what we call our bat cave. It's a room where the staff meets, you know, has the screens in front of them and they do it. But if there's a problem that's happening, if there's a patient that's having a problem with video connecting, then we will text the backup person. And for every class, there's a backup person, and that person will work with the patient so it doesn't disrupt the whole class. On the one time that we had a patient problem, and I think it might have been a fall related, we've had 1 fall or 2 falls total, we felt it was appropriate that we just said the session's canceled today, and so that we could work with just that patient. And everybody understood, but we had a backup person that was willing to always step in and help a patient that had a clinical problem that was non-emergent or a video connect issue. So how would we look going forward in terms of implementation? You could create your own program if you feel like this is something you can do. You've got the bandwidth, you've got the size. You could partnership technically with another program, and I'll let you see the advantages and disadvantages as they're there. But maybe you're at a larger hospital and you can help other hospitals and take their patients for the hybrid sessions, and the patients would go back to the referring center for the in-facility visits. You could develop some kind of partnership. And if you're the small hospital, you know, in Michigan, then maybe you would work with, you know, the Spectrum or the U of M or the Henry Ford, because they're offering hybrid for the virtual connections. Or there are vendor platforms that are out there. You can see how those articulate with you. So there are some options to go ahead and consider. Next slide. So moving forward on next steps, you want to collect data, relevant data. And whether that's number of visits, whether that's patient satisfaction, whether that's things that we're traditionally capturing in terms of functional improvement or quality of life. It could be operational efficiency. We have a staff person who is not part of the session once every couple of months sit in on at least one other staff person to view how the session is going and provide feedback in terms of quality delivery. So if Ann's the staff person that's running the session, I may sit in the back of the room and kind of audit her, and we'll talk about things later. And it's not a critical approach, it's a learning curve. So there's ways you can do it to make sure high quality care is being delivered throughout. Keep the patient the first of everything we do, and I come back to say, deliver all the key components of cardiac rehabilitation, and then get advice from people around you that are further ahead on the curve. And our group, there's, Alexis Beatty's group, I know Kate Trainer's delivered at Mass General. There's other programs that are out there, and I would encourage that as well.
And perhaps before we move into these questions, we'll just check in for, a last piece of advice or two from Ann to add on to the very useful suggestions that Stephen just made.
Yeah, I think, if I have any piece of advice, it's really just to, I feel like it's been a great addition to our repertoire of program offerings. And I would just encourage you to, go through the 6 questions that Stephen offered in this presentation. And if it seems like something that would work for your facility, to go ahead and at least explore how it could be done. Checking in from our perspective in the hospital, it was checking in with IT. They were extremely helpful in helping us with creating the platform. Certainly with patient financial services, the way that we bill now, it had to be set up. The patient's home had to be set up as a site of service. So they knew exactly what to do. As Stephen said, they're used to doing like virtual services now. So they knew exactly what I was talking about. Also, checking in frequently with our medical director and with the cardiology group. They were fine with it. They had some questions though, so I think it's really important to keep them in the loop as the program is developed. And I think you'll find that your team is interested in creating something like this too. I guess from a precautionary side, the main thing that bubbles up to me always is the financial piece. And I think we'll just all be watching really carefully to see where that goes from the Medicare perspective. But then also, as I mentioned, as Stephen mentioned earlier, to be proactive in approaching some of the commercial payers to see if they're willing to consider payment.
And just a final comment to me, and I think I may have mentioned this already, but for a lot of us, this is a black box. We just don't know what's underneath, and we're smart people. We can solve problems. So I would encourage you just to start to peel off the layers of the box until you get to where you want to go. It may take you 6 months, 8 months, it might have taken us 10 months to ramp this thing up. But we can do this in a judicious and quality manner. And I would encourage you to think about it or connect with others to help you along.
All right, thank you very much, Stephen and Ann. We want to encourage you, if you've been listening to this, to share an insight that you're going to take away from today's training or a question. Stephen Katayan is on, and we'd love for him to be able to respond to some of your questions. But I think one of the things that has surfaced in several discussions related to hybrid work groups is how many people can you actually support in a remote session, Stephen? Because some programs try to do this one-on-one, and that might not be feasible. So what do you see as the theoretical maximum number that you can support in a virtual exercise session?
So very, very good question. And as we started out, we did one-to-one, and there certainly are inefficiencies from a staff perspective in a one-to-one setting. And you can only talk to a patient so long in a one-to-one setting when you run out of things to talk about. So we moved in well over a year now, maybe 2 years ago, to using a WebEx format. And so we could do group visits. And we started with 1 to 2, 1 to 3, 1 to 4, 1 to 5, keeping it just like we would in a standard facility-based program. And over the course of in 1 hour, we asked patients to start their drop-in, so to speak, within the first 15 minutes or so of that hour, stay with us for 30 minutes of exercise, and then cool down during the last 15 minutes. So they might only be in it for about 40 minutes out of that 60-minute period of time, and it's gone very well. The staff likes it, the patients engage, just like an in-facility program. There's good conversation. We talk to them about it's a group setting, so if there's conversation that they don't want to share about themselves relative to their condition, then certainly don't feel like they have to interject it. But just like in a facility-based session, patients get talking, and it works very, very well. Staff now is much more efficient, where they're seeing 4 or 5 or 3 or 4 or 5 patients in a session.
Yeah, thanks very much. And let me just pose one more hard question that I think will resonate with the participants in today's session, many of whom have got programs that are under financial pressure. They've had staffing turnover due to the pandemic and the chronic labor shortages in healthcare. They're struggling to keep the doors open. They've got patients that are skittish, and cardiologists that are just kind of, perhaps they've got more patients now. So what do you say to someone that looks at all of this and says, look, the most I can possibly do right now is just keep the bare minimum going? How does hybrid, fit into their thinking, or how should it?
Well, timing is everything. So this is not, it's a great question. This is not a force feed. We are encouraging you, if you're interested in a non-traditional model, to help meet needs that you might have in terms of waiting list or reaching patients that live afar, with challenges to get into cardiac rehabilitation. This is one option for you to consider. If you start to go down the path, then 2 quick thoughts. One is, talk to people that are doing it now. Literally, email me. Our staff's willing to help talk to you about how we're doing it. Sit in on one of our hybrid classes if you want to. We can send you the link, and you can sit in and see what it looks like. So put your toe in the water and see how it goes. The second thing is, develop your champions. There's a physician champion. It may be your medical director. There'll be an administrative champion. Get them on board and see the rightness of this. If you don't want to buy in, this is where I started. If you don't want to buy in and say, we're just not going to do this now, the staff burden's too high. I'm down, right now at Henry Ford, I'm down 3.5 staff in cardiac rehab, 2.5 staff in cardiac rehab. Well, you may be the same. It might not be good timing. But if and when you're ready, use your resources, find your champions, and then slowly start to move forward. We want to do it correctly.
All right, thank you very much to Stephen and to Anne for their insights on today's session. We want to alert you to some resources that you can see on these next couple slides. These are things that we referenced during the training. If you want to read more about it, these are good resources that talk about how to do it, and more importantly, whether it's safe and whether it works well. So by all means, take a look at those if you have any interest. And then as we look ahead to next action steps, continue working on your care coordination activities in your facility. The Module 10 implementation guide has a lot of the insights from today's presentation, as well as additional suggestions that directly relate to the how of implementing. And then in your last peer action group, come to that prepared to discuss progress, challenges, and solutions to the activities that you're currently working on. So we want to thank Stephen and Anne again for their help this afternoon. We want to thank all of you for carving out time in a very busy schedule in the peak of vacation season to participate, and we look forward to talking to you all in your peer action groups next week. Thanks very much.